So this is the second part of the series of complete orthopedic for NEET PG. And in this, we will complete the whole syllabus, and 95% of the question NEET PG will be asked from these two videos. If you haven't watched the first video, go and watch it. Now let's start. The first question is, in pediatric oncology, which of the following malignancy is predominantly associated with bone metastasis under 6 years of age? And we have options like Wilms tumor, Ewing sarcoma, adrenal neuroblastoma, and retinoblastoma. So here we have to understand 5-6 points. That first point that you have to understand, that most common malignancy in bone tumor in bone is metastasis. Most common malignancy is metastasis. Second, most common site from where bone metastasis occur is breast. Third, most common bone where metastasis occur is vertebra. Okay, and generally from which side bone metastasis is not seen? Answer is brain. Okay, and in case of osteosarcoma, bone metastasis most commonly occurs where? Answer is lung. So these are the 4-5 points which you have to understand. That most common, if I ask you most common malignancy of bone, so your answer will be metastasis. Answer will be metastasis. And from where metastasis will come most commonly? Answer will be breast. And afterwards we will see that from the breast the metastasis is osteolytic as well as osteoblastic type both. It is a mixed metastasis. And which is the bone where most commonly metastasis occur? Answer is vertebra. These are the points. Okay. But if they use the term primary, that which is the most common primary malignancy of the bone, that means that originate in the bone, then your answer will be multiple myeloma. Then your answer will be multiple myeloma. It spreads through hematogenous mode. So if they ask you what is the most common malignancy of bone, metastasis. But if they ask which is the most common primary malignancy, then answer is multiple myeloma. After multiple myeloma, which is the most common primary malignancy? It is osteosarcoma. It is osteosarcoma. After osteosarcoma, it is chondrosarcoma. Chondrosarcoma. And after chondrosarcoma, it is Ewing sarcoma. But here is a catch. If they ask you most common malignancy, most common primary malignancy, which is non-hematogenous, then your answer will be osteosarcoma. So again, most common malignancy is metastasis that occurs from the breast. Most common site is vertebra, brain se metastasis. It is very rare. Most common primary malignancy, malignant multiple myeloma. Most common primary malignancy which is non-hematogenous, osteosarcoma. When you will give answer as Ewing sarcoma, if they ask most common primary malignancy under 10 years of age, then your answer will be Ewing sarcoma. So you have to remember 2 points regarding Ewing sarcoma, that most common primary malignancy under 10 years of age is, it is Ewing sarcoma. But please remember that Ewing sarcoma itself or Ewing sarcoma per se has the maximum tendency to occur in second decade of life. So these are the two important questions. One, which is the most common primary malignancy under 10 years of age? It is Ewing sarcoma. But Ewing sarcoma has the tendency to occur per se itself in the the maximum incidence of Ewing sarcoma is in the second decade. Okay. Now this question, we have understand that most common malignancy of bone is metastasis. Primary is multiple myeloma. But if they ask most common metastasis, I have told you this question is asking in pediatric oncology, which are the following malignancies predominantly associated with bony metastasis under 6 years of age. So I have told you the most common location from where metastasis occur is breast. But if they ask you especially under 6 years of age, then your answer will be adrenal neuroblastoma. So these This is slightly confusing. Most common malignancy, metastasis, most common site, breast. But if they ask which is the most common site under 6 years of age, if they ask under 6 years of age, metastasis comes from which tumor, then your answer will be adrenal neuroblastoma. So they can ask this question because this is an exception. Otherwise, your answer will be breast. Okay. So this I have told you. So most common, least common, these things you have to understand. So I've told you that most common malignant. So just revise it. Most common malignancy of the bone is metastasis. Most common site from where metastasis occurs is it is the breast. Most common site where metastasis occur in children less than 6 years, adrenal neuroblastoma. This was the question that is asked. And most common bone where metastasis occurs, answer is vertebra. Vertebra is the most common. Now, if they ask you which is the most common non-malignant lesion, your answer will be osteoid osteoma. And they have also, it contains nidus. It contains nidus. And what is the most common age of osteoid osteoma? It is second to third decade. Second to third decade. And what is the most common site? It is diaphysis of femur. That is diaphysis of femur. So most common non-primary non-malignant lesion you have answer is osteoid osteoma. It occurs in the second to third decade and most common location. All this it consists of nidus and most common it occurs at the diaphysis of the femur. Then there occurred most common primary malignant lesion. So I have told you MOCE, MOCE, multiple myeloma, it is hematogenous. But if they ask non-hematogenous, your answer will be osteosarcoma, chondrosarcoma, and Ewing sarcoma. And I have told you that most common primary malignant lesion under 10 years is Ewing sarcoma. But Ewing sarcoma has maximum tendency to but Ewing sarcoma has maximum tendency to occur in the second decade. So Ewing sarcoma is the most common primary malignancy under 10 years, but Ewing sarcoma per se has the maximum incidence of occurring in the second decade. So these are some most common, least common thing which can be. If you remember this much, you can solve the question. So now you have a question. Which of the following is true regarding radiosensitivity of metastasis tumor? So we have four options. All metastasis tumor are radiosensitive. No, some are radiosensitive, some are radioresistant. Metastatic tumors from renal cell carcinoma are radiosensitive. This most metastatic tumor are radioresistant except renal cell carcinoma. And metastatic tumor from breast are least radioresistant. So this we have to see which are radiosensitive, which are radio. Now, so if we ask what are the radio resistant tumor. So if a tumor has sarcoma, so generally it will be radioresistant. For example, osteosarcoma, chondrosarcoma, fibrosarcoma. Okay, so everyone has the sarcoma. Then malignant fibrous histiocytoma. So you have to remember these four are highly radio resistant. Okay. Then radiosensitive tumors. So radiosensitive tumor you have to remember triple M LE. Multiple myeloma. Multiple myeloma is radiosensitive. This L is for lymphoma. This E is for Ewing sarcoma. And this M is for metastasis. Now here is a catch. Most of the metastatic tumor are radiosensitive except the metastasis of renal cell carcinoma. So renal cell carcinoma you will consider as radio resistant. So now if we know this, now again all metastatic tumors are radiosensitive. This is false. Metastatic tumor from renal cell carcinoma radiosensitive. But we have just seen that uh, metastasis tumors are generally radiosensitive, but exception is renal cell carcinoma. Renal cell carcinoma is radioresistant. So this is also false. Most metastatic tumors are radiosensitive except renal cell carcinoma. Yes, this is the right answer. Metastatic tumor from breast are least radiosensitive. And this is also wrong. So our answer is third. So you have to remember which are radioresistant, which are radiosensitive, which are radioresistant, and this renal cell carcinoma metastasis are radioresistant. Okay. So tumor radiosensitive, I have told you. Whenever I'm talking of radiosensitive, I have told you you have to remember triple MLE. Triple M multiple myeloma. Next M metastasis, but except renal cell carcinoma, they are radio resistant. So they will go here. Okay, all the metastases are radiosensitive except renal cell carcinoma. And then E is for Ewing sarcoma and lymphoma. They both are radiosensitive. Ewing sarcoma, it is said that it melts when radio waves are given. Okay. Then radio resistant tumor, radio resistant. You have I have told you sarcoma, osteosarcoma. Then again sarcoma, fibrosarcoma, sarcoma, chondrosarcoma, and malignant fibrous histiocytoma. So this has been as malignant fibrous histiocytoma. So this you have to understand. Which is the most common age and location of adventioma? This question has been asked. Now, so adventioma, always remember this T. This T, you can remember, it is the T for tibia. So it occurs on the diaphysis of tibia. And from this T, you remember 20. Age of presentation is 20 to 40 years. Okay. So adventioma, second location, it can also occur in the mandible. So if you can remember, please remember this adventioma is associated with soap bubble appearance. See, there are actually two tumors which are associated with soap bubble appearance. But some books also mention three. And which are they? One is adventioma. Second is GCT, that is osteoclastoma, giant cell tumor. And third is simple bone cyst. But most of the standard book says that these are the two books with the two tumors which are associated with soap bubble appearance. That is adventioma and GCT, that is adventioma and GCT. But some book also say simple bone cysts are also associated with the uh, soap bubble appearance. So answer will be, it will be the diaphysis of tibia and 20 to 40. This will be your answer. So now there are lot of questions which have been asked on the tumor and what is the age and what is the location of the tumor. For example, if we ask osteosarcoma, what is the most common age? Can anybody tell me what is the most common age for osteosarcoma? Second decade. Second decade. But please remember, it shows bimodal presentation. So it can also present in the sixth to seventh decade. So it shows bimodal presentation. So they can ask you which is the tumor which can present in early age as well as after in the old age. That means which of the tumor has a bimodal presentation. So your answer will be osteosarcoma. It can present in the second decade as well as 6 to 7 decade. And what is the most common location? Most common location of the osteosarcoma is the distal metaphysis of femur. Distal metaphysis of femur. Now, second, it is upper tibia. Third, it is distal humerus. So most common distal metaphysis of the femur. We will study its radiological finding that it shows sunburst, sun-ray appearance, and Codman triangle periosteal reactions. Okay, so this is osteosarcoma. It shows bimodal presentation, second decade to sixth decade, sixth, seventh decade. Most common distal location is distal metaphysis of femur, followed by upper tibia, followed. Then after osteosarcoma, they can ask you what osteoclastoma and osteoblastoma. Okay, so osteoclastoma is nothing but giant cell tumor. So most common presentation is second to fourth decade. To be more specific, it is from 20 to 45 years. Giant cell tumor or osteoclastoma occurs after fusion. 2 points of remember. It occurs after fusion of the growth plate, and it is the only tumor which can invade till the um, uh, joints. So it can even invade to the joints. Okay. So osteoclastoma, second and most common site where osteoclastoma occurs, it occurs in the epiphysis of distal femur. Epiphysis of distal femur. ठीक है? And most common is 2 to 4 decade. Now osteoblastoma, it occurs in second to third decade, and it posterior column, and most common location is posterior column. Am I visible? Posterior column of vertebra. Posterior column of vertebra. So osteoblastoma, most common location, this has been asked several times, posterior column of the vertebra. Let me now. Now it will be posterior column of the vertebra. Now third is Ewing sarcoma. Ewing sarcoma. So for Ewing sarcoma, remember this is E. Before E, what comes? D. What after comes after E? F. And E means 5. So D for diaphysis, F for femur. So most common location of Ewing sarcoma is diaphysis of the femur, and age of presentation is 5 to 25 years. This you can remember like this. Okay, if they this you have to remember about Ewing sarcoma. What is the most common presentation? 5 to 20. It generally present with fever, raised TLC, anemia, raised ESR, raised CRT. Very important word. And it is highly radio sensitive. It melts like ice. Okay, so this is one. So these are the four very important tumors whose location you have to. Then we have a simple bone cyst and we have aneurysmal bone cyst. Both occur under 18 to 20 years. Simple bone cyst. Simple bone cyst most commonly occurs in the upper end of humerus, upper end of humor metaphysis, and aneurysmal bone cyst also occur in the metaphysis. So both are simple bone cyst and ABC aneurysmal bone cyst both occur under 18 to 20 years. Both are metaphyseal tumor, and but simple bone cyst in most of the cases you will see in the upper humerus metaphysis. Okay. Now there are two very important tumors which you have to understand. One is enchondroma and second is osteochondroma. Because a lot of questions they are asking with this. Now enchondroma, most common age of presentation is 4th to 5th decade. Osteochondroma, it is less than 18. It is not a true tumor. It is actually exostosis. Exostosis. It is exostosis. Most common is it occurs in the distal femur area. Inchondromas mostly occurs in the metaphysis of bones of hands. It occurs in the metaphysis of bones of the hand, inchondroma. In osteochondroma, distal femur. If this is the distal femur, it is like the growth, which is known as exostosis. It is not a true tumor. Osteochondroma, inchondroma, most common is fourth to fifth decade. And osteochondroma less than 18 years. Inchondroma most commonly occurs in the metaphysis of the bones of the hand. Now, very important point, very. Inchondromas are associated with a syndrome that is Maffucci syndrome. Maffucci syndrome. It is associated with Maffucci syndrome. What is Maffucci syndrome? In Maffucci syndrome, you have inchondromas plus hemangiomas in body. Okay. And very important, these inchondromas can go malignant change and can form chondrosarcomas. Okay. So inchondromas, osteochondromas, you have to remember inchondroma is associated with Maffucci syndrome, which is associated with Maffucci syndrome is inchondromas plus hemangiomas, and Maffucci syndrome, this inchondroma can go into the malignant transformation and can form the chondrosarcoma. These you have to understand. Then very important, I have told you adamantioma. Adamantioma. I have told you, remember T, that is 20 to 40 years, most common age of presentation, and most common tibia diaphysis, and associated with soap bubble appearance. Soap bubble appearance. I have told you soap bubble appearance is associated with mainly two tumors, that is GCT, giant cell tumor, that is, we can remember सोप से ग्रेट एडम नहाता था. So the great Adam used to take bath with the soap. So great say GCT, that is giant cell tumor, osteoclastoma, and Adams, that is adamantioma. So you can remember from this that. But some books also say that soap bubble appearance is also seen in simple bone cysts. So you can also take it. Adamantioma. Now, a very important tumor, that is chordoma, which was asked around 2 to 3 years back. Chordoma, most common site is sacrum, and most common age of presentation is fifth to seventh decade. It is a tumor of old age. Chordoma. Most common site sacrum. Most common site. It consists of physically ferrous cell. The question that they have asked, they have shown the MRI of the patient, and they have asked you that there is a 55 years old patient with the highly malignant tumor in the sacrum, and it is showing physically cell. So even if you don't know physically formed cell, if you simply know that chordoma most commonly occur in the fifth to seventh decade, and most common is location is sacrum, you could have solved that question. But now please remember about this chordoma. Then comes the fibrous dysplasia. Fibrous dysplasia. What is the most common age group? Under 30 years. Fibrous dysplasia. Sorry. I will write here. Fibrous dysplasia. Fibrous dysplasia. It commonly occurs under 30 years of age, and it is upper end of femur. Upper end of femur. And it occurs on the upper end of the femur. It occurs on the upper end of the femur. Then you have a multiple myeloma. Multiple myeloma. What is the most common site? It is the vertebra. It is the vertebra. They have also asked what is the most common presentation of multiple myelomas. The most common presentation is bone pain. Most common presentation is bone pain. And most common site is vertebra. Most common age, it is just like chordoma. Fifth to seventh decade. Fifth to seventh decade. Okay. So this things you have to remember. If you know the tumor's age and location, you can very easily solve a lot of MCQ just by knowing the age and the location. Now, so this you have understand now. So now just revise it again. Osteosarcoma, it occurs in the distal femur metaphysis. I have told you. It occurs in the second decade, also on the sixth decade. So it has a bimodal presentation. If anyone asks you, he, at which is the tumor which present has bimodal, answer will be osteosarcoma. Then we have a osteoblastoma. It occurs in the posterior column of vertebra and from second to the third decade. This is osteoblastoma. Osteoblastoma. Then we have osteoclastoma. Osteoclastoma occurs in the distal epiphysis of the femur. And what is the most common age? Second to the fourth decade. More specific, 22. This is also known as GCT, giant cell tumor. Then I have told you Ewing sarcoma, diaphysis of the femur 5 to 20. I have told you the technique, write E, write D, E and 5. Diaphysis of the femur and 5 to 25. Ewing sarcoma. But Ewing sarcoma, I have told you, has maximum tendency to occur in second decade. It is the most common primary malignancy under 10 years of age is Ewing sarcoma, but it has a tendency itself. It has a tendency to occur mainly in the second decade. Okay. Then we have a simple bone cyst and we have a aneurysmal bone cyst. I have told you both are under 18 years. Both are metaphyseal. But simple bone cyst is generally seen in proximal humerus. Proximal humerus. Then I've told you about inchondromas and osteochondromas. Inchondromas mainly occur in the fourth to fifth decade and metaphysis of bones of hand. And I've told you that it is associated with morphosis syndrome. Inchondromas are associated with the inchondromas. Inchondromas are associated with morphosis syndrome. What is morphosis syndrome? It consists of inchondromas and hemangiomas, and this inchondroma can convert into the chondrosarcoma. It can convert to chondrosarcoma, and yes, chondrosarcoma has a rule of P. That is, it is seen in pelvis, proximal humerus, and proximal femur. And what is the treatment? White excision or the radical excision. And very important point which I forget, it shows a special type of calcification. It shows a special type which is called as coma calcification or punctate calcification or popcorn calcification. Popcorn calcification. So please remember this. Chondrosarcoma shows calcification which can be coma or punctate or popcorn calcification. Okay, chondrosarcoma. Very important point regarding this. They have also asked one time which tumor shows chicken wire calcification. So you blast the chicken. That is chondroblastoma. 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 So it shows chicken wire calcification. It shows chicken wire calcification. Chondroblastoma shows chicken wire calcification. And chondrosarcoma, it shows punctate, coma, or popcorn calcification. This is very important. Now I've told you about adamantioma, 20 to 40 years, tibia, diaphysis, also so-called appearance, fibrous dysplasia under 30 years, upper end of the femur, chordoma, fifth decade, sacrum, multiple myeloma, fifth decade, vertebra. Osteoblastoma, I have already told you, it is from second to the third decade. It is the most common primary non-malignant tumor in the diaphysis of the femur. It can also occur in the diaphysis of tibia. Okay, so this is it, and it contains nidus. This has been asked a lot of time. Earlier in UPPGM, there used to be a lot of time they used to ask which is the bone lesion which contains nidus. An answer used to be osteoid osteoma. Okay. Now this identify the sign and identify this sign. Can anyone identify this sign? What you are seeing, this is a eye, this is an eye, but here the eye is closed. Here the eye is open, here the eye open, this is the eye is closed. So this sign, and here you see, if this area, here you can see the pedicel, here you can see the pedicel, here you can see the pedicel, but here the pedicel is not seen. So basically this sign is called as winking owl sign, winking owl sign. It's looking like owl is closing his eye, winking his eye. This is known as winking winking owl sign, winking owl sign. It is seen in cases of vertebral metastasis, vertebral metastasis. This is seen in cases of vertebral metastasis. A very important point. You have to understand, if this is your anterior part and this is your posterior part, I think I'm visible. Okay. So this is the vertebral body. Then from the vertebral body we have pedicel. Then from the pedicel we have transverse process, and then we have lamina, and lamina join to form the spinous process. So this is vertebral body. This is pedicel. This is lamina, and this is transverse process, and this is spinous process. Spinous process. So what happens whenever there is a metastasis? Whenever there is a metastasis, this pedicel is destroyed. This pedicel is destroyed, due to which when we see from in the AP view, this pedicel is not visible. And when this pedicel is not visible, it appears like an owl is closing his eye, which is known as winking owl sign, seen in vertebral metastasis, caused because of pedicel destruction. So you have to remember three things. Winking owl sign seen in vertebral metastasis, seen in AP view of the X-ray. It is not a CT scan finding, and it is caused because of pedicel destruction. Pedicel destruction. Okay, so this you have to understand. So these are the things that you have to understand. It is the winking owl sign because of the vertebral metastasis, because of the destruction of the pedicel. You have to understand this. Okay. Now, can anybody identify this sign? Can anybody identify this sign? This sign, and this sign. Here, it is seen like a, you see jail, in jail like these bars are present. So it is like a bar. So this sign is known as jail house sign. Jail house sign. And this is looking like polka dot. Girls are, there are fashion of wearing polka dot skirts and things. So this is known as polka dot sign. Polka, polka dot sign. Please remember, polka dot sign is seen in transverse section, and polka dot sign is seen in transverse section, and it is seen in CT scan. Okay, these two signs are seen in hemangiomas. These are seen in hemangioma. So jailhouse sign or polka dot sign, this is seen in hemangioma. There is one also sign, important sign. Can anybody tell me one? Can anybody tell me there is a third sign which can also be seen in hemangioma? That start with a C. After C comes O, then R, Cor, then come D, then come U. So I have told you the initial five letters CORDU. Now I can give you the hint. There are three more letters present. There was a movie of Ranbir Kapoor, which was the most flopped movie, Roy. So this is corduroy appearance. Corduroy appearance. That is known as CORDUROY. Corduroy. So in vertebral hemangiomas, you see three signs. First is jailhouse sign, just like a jail. Second is polka dot sign, which you see in the transverse. Sorry. Uh, second is the second is the on the transverse section of the CT scan we see it is the polka dot sign, and third is the corduroy sign. These are the three signs which we see in the vertebral hemangioma. So you have to remember. So identify the sign and okay. So I have told you. Please remember them. So it is the jailhouse sign, then CT transfer section you see polka dot sign, and then it is also corduroy sign. These three signs are seen in vertebral hemangiomas. You have to remember them somehow. Now identify the sign and the pathology. Identify the sign and the pathology. Now very important point. Now this you can, if you have listened to my lecture till the time, you can easily solve this question. See, this is fibula and this is tibia, and this is soap bubble appearance. Soap bubble appearance. I have told you that soap bubble appearance is seen mainly in two areas. That I have told you the mnemonic that with the soap, who washes his body? Great Adam. That is giant cell tumor. That is osteoclastoma. Or second is adamantioma. And some book also mentioned SBC, that is simple bone cyst. Now, adamantioma, it occurs, giant cell tumor, I have told you, it occurs in the epiphysis, most commonly at the age of after 18 years. So this is the diaphysis. So it cannot be giant cell tumor. Simple bone cyst, I have told you, it occurs on the metaphysis, not the diaphysis. Secondly, most common location of simple bone cyst is upper humerus. So more, and this is tibia. I have told you that adamantioma, remember T for tibia, it occurs on the diaphysis of the tibia and most common is 20 to 40 years. So just by, if you have listened to my lecture till the time, you can easily say that this is the soap bubble appearance in the diaphysis of tibia, and it is highly suggestive of adamantioma. Adamantioma. Okay, so this is the answer. Okay, so I've told you it is a soap bubble appearance, adamantium of tibia. Soap bubble appearance is also seen in GCT, but GCT occurs in the epiphysis. So if you remember these things, you can easily solve this question. Now, so please remember there are important signs related to the tumors which you have to know. So first is the osteosarcoma. Osteosarcoma, and everybody know this is a lot of time this question has been asked. What is the osteosarcoma? Osteosarcoma, it is the, what is the sign? It is the Codman triangle. You see Codman triangle. If this is a triangle, this is periosteal elevation due to which a triangle is formed. Codman triangle. Second is sunray appearance. Sunray appearance. Sunray appearance. Why? Because if these are the blood vessel, so this malignant bone grows in the direction of the blood vessel. So it appears like a sunray. This is called as sunray appearance. Then osteosarcoma, then Ewing sarcoma. Ewing, everybody knows onion peel appearance. Onion peel appearance. Onion peel appearance. Very important fact. It is asked a lot of times. It has been asked. Then we have a simple bone cyst and we have aneurysmal bone cyst. In simple bone cyst, what happens if this is the bone, fragment of bone is present inside the lesion. So this is called as fallen fragment sign. This is known as fallen fragment sign. This is known as fallen fragment sign, or it can also be called as trap door sign. Trap door sign. It is known as fallen fragment sign, also known as a trap door sign. What in invisible bone cyst, what you will see, and some also say it also have soap bubble sign. Soap bubble sign. In aneurysmal bone cyst, what are the signs? You see double liquid density sign. Okay, double liquid density sign because there is some serum, some blood, and some water-like area. So double liquid density sign or intralesional septation. So the correct term is not soap bubble; it is intralesional septation. Okay. So these are some important things that you have to understand. Sign. Now coming to the uh, uh, yeah, fibrous dysplasia. Fibrous dysplasia, most common involved area is the upper femur. And please remember two deformity. One is the ground glass appearance. Ground glass appearance. It shows ground glass appearance. And second is Shepherd Crookes deformity. Shepherd Crookes deformity. Shepherd Crookes deformity. Ground glass appearance and Shepherd. Then soap bubble sign. Soap bubble. Soap bubble sign. I'm writing here because otherwise it will not be visible. Soap bubble sign is seen in adamantioma. I have told you, remember giant atom and GCT, that is osteoclastoma. Okay, see this. So it is adamantioma. This is adamantioma, and this is C. This is osteoclastoma. Teoma. Okay, clastoma. Osteoclastoma. Now, then there are some other, for example, very important. If you understand, I have told you vertebral hemangiomas. Vertebral hemangiomas. I have told you there are three important signs. Jailhouse sign. Then we have a polka dot sign, which we see on the CT scan transverse section. Then we have a corduroy sign. These three signs you have to remember. Then in multiple myeloma, you see moth-eaten appearance, or punched out lesion. So if this will be bone, you will see a radiolucent or black areas, punched out areas in the skull, and similarly you can see in the vertebra. This is called as moth-eaten appearance, or it is punched out lesion. So these important radiological findings you have to understand. So let's see. Let's why. So in osteosarcoma, Codman triangle, sundry appearance. In Ewing sarcoma, we see onion peel appearance. In soap bubble, we see GCT and adamantioma. We have to remember basically three. Now this fibrous dysplasia, ground glass appearance, and Shepherd hook deformity. I have told you. Remember. Vertebral metastasis, we see winking out also. I have just shown you that question, winking out. Why it occurs? It occurs because of the pedicel destruction. It occurs because of pedicel destruction. Then vertebral hemangioma, we see polka dot sign, jailhouse sign, and corduroy sign. And multiple myeloma, we see moth-eaten or punched out appearance. So if you know these much signs, you can easily solve the question. Now coming to the next question. A patient of Maffucci syndrome has persistent hyperglycemia because Maffucci syndrome. Why I will have hyperglycemia? Why he will have hyperglycemia? Because it is a paraneoplastic syndrome. So Maffucci syndrome consists of inchondromas and hemangiomas and can have paraneoplastic syndrome in the form of hyperglycemia, hypercalcemia. Okay. So that means what does it show? That means that Maffucci syndrome is generally attached to the inchondromas. It has inchondroma. But if it has started if inchondromas can convert into chondrosarcoma, then you will see paraneoplastic syndrome. So presence of persistent hyperglycemia, although it can be because of diabetes, but because of in MCQ, if this show some paraneoplastic syndrome, that means they are trying to tell you that now that inchondroma has converted into the chondrosarcoma. Okay, so now which of the following tumor can be presentation? Now nowhere in the option they have given in chondromas. So what will be the answer? Chondrosarcoma. This was the question which was asked in NICT. Chondrosarcoma. It follows rule of P. It occurs in the pelvis, proximal humerus, proximal femur. It shows three calcification like popcorn, comma, and punctate calcification. And chicken wire calcification is seen in cases of chicken wire. It is seen in blast. It's blast the chicken. Chondroblastoma. Chondroblastoma. You see chicken wire calcification. The answer is B. What is the characteristic of Ewing sarcoma? Now they are asking you the characteristic of the Ewing sarcoma. First is high presence of reticulin fibers, a small round blue cell rich in glycogen, large pleomorphic cells, and presence of necrosis. Which is the answer? The answer is B. It consists of small round blue cells which is rich in glycogen. That is why on histology it is PAS positive. And since the reticulin is absent, it is reticulin negative in the histology of Ewing sarcoma. Now I am telling you a very important point regarding Ewing sarcoma histology. Ewing sarcoma histology is of no use in the grading of tumor. Why? Because all Ewing sarcomas are taken as a high grade malignant tumor. So there is no point of grading them on the basis of histology. So practically Ewing sarcomas histology consists of round blue cells which have a high content of glycogen, so they have PAS positive. They don't have reticulin, so they are reticulin negative. But practically or histologically, there is no use of histological grading of Ewing sarcoma because all Ewing sarcomas are considered as high grade tumor. So if they ask you which of the following tumor does not need histological grading or histology is not needed, so your answer will be Ewing sarcoma. Pleomorphic cell is seen in cases of osteosarcoma histology. Osteosarcoma histology. In osteosarcoma, you will see pleomorphic cell surrounded by the osteoid. Pleomorphic cell surrounded by the osteoid. So in osteosarcoma, you will see pleomorphic cell surrounded by the osteoid. Okay. So there are some points, important points regarding Ewing sarcoma that I want to write here. First, I have told you that Ewing sarcoma most common age of presentation is 5 to 25 years. I have told you it is the tumor most common malignant tumor under age of 10 years. Under age of 10 years, it is most common malignant tumor. But if I ask you maximum tendency of Ewing sarcoma, it is in second decade. It is in second decade. Okay. Now, if I go most common location, so most common location is diaphysis of femur. Third, very important point, I have told you about presentation. It can present with fever, raised TLC, anemia. So, if you are showing with X-ray and these features are shown, there are high chances that answer will be Ewing sarcoma, raised ESR, raised CRP. So if along with the tumor in the MCQ they are showing these things, that raised TLC, raised WBC, that means it is high chances that this is Ewing sarcoma presentation. Then on radiological finding, I have told you it shows onion peel appearance. It shows onion peel appearance. On histology, it shows round blue cells rich in glycogen. So they are PAS positive and reticulin negative. Reticulin negative. And there is no use of doing histology in case of Ewing sarcoma because all Ewing sarcomas are taken as high grade tumors and these are highly radio sensitive. They melt like ice. Now, very important things. Ames has two times asked a question regarding the prognosis of Ewing sarcoma. They ask that what are the things that show that this Ewing sarcoma has poor prognosis. So I am writing here what are the things which says poor prognosis. It consists of 4 or 5 points, but most important is distant metastasis. If it has shown distant metastasis, that means it has a very poor prognosis. Second, if along with Ewing sarcoma it is showing anemia, raised WBC, raised ESR, which I have shown you, a lot of people present, that means it is a marker of poor prognosis. Then age 12 to 15 years, males, male. And fourth point, size and location. Now, what you have to remember is, even for practical purpose and for MCQ purpose, nowhere in the prognosis histology is involved. This is what I am trying to explain to you. That histology is of no use. In most of the tumors, if you see the prognosis score, every tumor has histology part. But Ewing sarcoma is the only tumor which does not histology as of no use. So in the option, they will, instead of remembering these 4 points, just remember this distal metastasis. Just remember that histology is of no use. So you can answer that question. They have asked this question 2 times. Okay. And the correct answer was histology. That means that was not involved in the prognosis of Ewing sarcoma. Okay. So important points I have told you. I am again revising it. Age is 5 to 25, most common malignant tumor, less than 10 years, but it has maximum tendency to occur in second decade. Diaphysis of femur, radiology onion pale appearance, histology round blue cell. Okay. Most not important. Histology is not important as all Ewing sarcoma are high grade, glycogen is present, and reticulin is absent. Can present with fever, increased WBC, anemia, ESR. I have told you. Point for prognosis. All the 4 points I have told you. Most important is distant metastasis. Then fever, WBC, ESR is male age 12 to 15 years, and then size and location of the tumor. So these 4 points you have to remember very. These 4 points. These 4 points. Remember them very. Okay. This size and location of the tumor. This is least. Then male and age. These 2 points you can forget. But please remember the other 2 points. Okay. Not very important thing. A lot of question you asked that I have told you metastasis. Most common tumor of bone is metastasis. Most common site from where it comes is breast. But under 6 years, it is a neuroblastoma. Now, so when the metastasis occurs to the bone, it can cause lysis of the bone, that it can be osteolytic. It can cause new bone formation, that is osteoblastic. And third, it can cause mixed factor. So a lot of time MCQs are asked. So you have to remember which is osteoblastic. So please remember how to remember osteoblast. If you want to do blast, just remember a story. You have to, if you do a blast in front of girls, you have to sing a poem. POEM. Okay. You have to sing a poem. If you want to do blast, you have to sing a poem. So POEM. Everything has a tumor. So P is for prostate. So prostate shows osteoblastic. O is osteosarcoma. Osteosarcoma. If it goes to the other bones. E is for exception. Medullary carcinoma thyroid. So why this is exception? Because most of the thyroid cancers are osteolytic, but this medullary carcinoma is osteoblastic. This you have to remember because a lot of time this question has been asked. Although they haven't asked it in the last 5 to 6 years, but earlier they used to ask this a lot of time. So when you do want to do osteoblast, you have to sing a poem. P is for prostate cancer, O is for osteosarcoma, E is exception, that is M for medullary carcinoma thyroid. Because most of the carcinoma thyroid are osteolytic. Okay, now it is thyroid cancer except in osteolytic, except medullary carcinoma thyroid. This is the first. Now MM. 1 mm is malignant melanoma. The other is multiple myeloma. I have told you it shows moth-eaten appearance or punch out lesion. And fourth is renal cell carcinoma. Okay, these are four osteolytic. Now, how to see mixed metastasis? Whenever mixed terms come, you know there are girls. Girls have mixed opinion about everything. Please don't take on her. This just to make you remember. Mixed girls have every, and it's slightly non-veg type. Girls have mixed opinion about everything. Mixed opinion about everything. So whenever mixed comes, you think of girls, and when you think of girls, so breast carcinoma, and what is behind breast? It is lung carcinoma. And third from L you have lymphoma. Okay. So breast, what is under the breast? Lung carcinoma, and from this L you get lymphoma. So these are mixed metastases. Please don't take, otherwise you have to remember. So mixed is for breast carcinoma, lung carcinoma. If you remember this chart, you can easily solve the question related to osteolytic, osteoblastic, and mixed metastasis. Okay. Okay. So this I have told you mixed is breast, lungs, lymphoma, osteoblastic poem, prostate cancer, osteosarcoma, and exception is medullary carcinoma thyroid. And osteoclastic is all thyroid carcinoma medullary. Then we have a multiple myeloma, malignant melanoma, and renal cell carcinoma. So you can now identify the fracture and name it. Now this is C2 fracture. Okay, this is the C2 fracture. I have just told you that if this is the vertebral body, then these are the two pedicel. This is transverse process. This is the lamina, and this is the spinous process. So this is pedicel. This is lamina. This is a transverse process, and this is the spinous process. Plus, they have a superior facet, and they also have inferior facet. Now, so if this is first vertebra, this is second vertebra, between the superior facet and the inferior facet, there is the part of bone is known as pars interarticularis. What is that known as? That is known as pars interarticularis. Pars interarticularis. Pars interarticularis. Pars interarticularis. This is the area between superior and inferior facet of two vertebrae. The upper vertebra, lower vertebra, superior facet and inferior. So between the facets, the area of the bone is pars articularis. Anterior to pars articularis is pedicel, and posterior we have lamina. So this is the fracture C2 of involving the pars articularis. And whenever there is a fracture of pars articularis anywhere in the spine, that is called as spondylolysis. So what is spondylolysis? Spondylolysis is fracture of the pars interarticularis. And if the upper vertebra slips anterior or posterior with respect to the lower vertebra, that is called as spondylolisthesis. Is spondylolisthesis. Okay, so there are two things: spondylolysis, which is the fracture of the pars interarticularis, and spondylolisthesis, which is the movement or the displacement of the upper vertebra with respect to the lower vertebra. Generally, upper vertebra comes anterior, so it is known as anteriolisthesis. Okay. So what happened? It is C2 fracture which consists of spondylolysis, that is pars interarticularis fracture of C2, plus there is also, you see, the C2 has come anterior compared to C3, that is anteriolisthesis, that is also spondylolisthesis. So there is spondylolysis as well as spondylolisthesis. C2, so this is called as hangman fracture. This is known as hangman fracture. This is known as hangman fracture, which involves C2 pars interarticularis fracture of C2 and anterolisthesis of C2. That means spondylolysis and spondylolisthesis both are involved. Similarly, if there is a fracture of C1, that is called as Jefferson fracture. Jefferson fracture. So C1 Jefferson, C2 hang. C1 Jefferson, C2 hangs. Okay. So this is the pars interarticularis fracture, C2 spondylolysis, and plus C2 anterolysis. So this is called as, and if the C1 fracture occurs, that is called as Jefferson fracture. Identify a sign. Now what do you see here? Just see, very important. This is a very important picture. This has been asked in NEET teaching. This is L5, this is 4, this is 3, this is 2. You are seeing that 4 has displaced over the L5. That means there is anteriolisthesis. There is anteriolisthesis. Okay. So there is anteriolisthesis of L4. And also if you see here, there is fracture of, see this, pars interarticularis of L4. That is, there is also spondylolysis of L4. And this is known as this L4, that is anterolisthesis, along with the pars interarticularis fracture of L4, that is spondylolysis. This is known as B-headed dog sign. B-headed dog sign. This is known as B-headed dog sign. B-headed dog sign. Okay. What there are two things. One is anterolisthesis of L4 over L5, and second is spondylolysis, that is pars interarticularis fracture of L4, and due to which there is a B-headed dog sign. Okay, so this you have to understand. This has been asked in B-headed dog sign, L4 pars spondylolysis, and anterolisthesis of L4. Identify the sign in pathology. Very favorite question. Now, if you see, this appears like a what? Napoleon hat, but it is inverted. So this sign is known as inverted Napoleon hat sign. This is known as inverted Napoleon hat sign. This is known as inverted Napoleon hat sign. What is there? We know that we have L5 and then we have sacrum. So in this, when we see inverted Napoleon hat sign, when there is pars interarticularis fracture of L5 both sides, because we have pars interarticularis both sides. So when we have a bilateral pars interarticularis fracture of L5 plus anteriolisthesis, that is anterior movement of L5 over sacrum. When we see these two things, then we call it as an inverted Napoleon sign. I'm again telling, inverted Napoleon sign is seen when there is bilateral pars interarticularis fracture of L5 plus anteriolisthesis of L5 over sacrum. It is called as inverted Napoleon sign. There is heightened lordosis, very high lordosis. Okay, so a very high you will see a very high lordosis. Lordosis. So this is inverted Napoleon sign, bilateral spondylosis, L5 fracture of pars experience, and is anterior recess of L5 4 sacrum. I explained everything. In case of paracentral disc prolapse of L4, L5, which nerve is most likely to be compressed? This is a very important question. Now, if we see these are two vertebral bodies, and so disc can come like this central, it can come out through lateral, and it can come out paracentral. Okay, so this bulge can be lateral, it can be paracentral, and it can be central. These are three kind of disc prolapse. Please remember, in practical life, it is mixed. But in MCQ, if they ask you which is the most common type of disc prolapse, you have to answer it is paracentral. Paracentral disc prolapse. It is the paracentral disc prolapse which is the most common type. Now, if this is L4 and this is L5, if there is a lateral disc prolapse, L4 root will be affected. L4 root will be gone. In case of paracentral, L5 root, that is the lower root will be gone. So in lateral, the above root, that is L4. For example, if there is L3, L4, so in lateral, L3 will be gone. In paracentral, L4 will be gone. Similarly, in L4, L5, in lateral, L4 will be gone. In paracentral, L5 will be gone. And in case of central, you will have chorda equina syndrome. That is bowel and bladder involvement plus perianal anesthesia. Okay, chorda equina syndrome. So paracentral. So if now this have asked in case of paracentral disc prolapse at L4, L5, which nerve root is most likely to be compressed? L4, L5 paracentral, that means paracentral means lower will be gone, that means L5 will be gone. Answer will be L5. Now if I ask you what will be the symptoms, so you can also tell the symptom. For example, if we have L4 and L5, okay, so and uh, there can have paracentral, okay, now this is L4, this is L5, okay, there can be paracentral and there can be lateral. If paracentral involved, then L5 will be gone. If lateral, L4 will be gone. So what are the sensory problems you will see? What will be the motor problem see? Which reflex you will go? So they can ask you this kind of question. And if L now in first you will see sensory supply. Now L5 supplies which area? Lateral leg plus dorsum of foot. L4 supplied medial leg, medial thigh. So this will be gone. Motor L5 helps in dorsiflexion of foot plus extension of foot. And L4 is help in is knee extension. So when L4 will be gone, there will be weakness in knee extension. When L5 will be gone, that is in paracentral, dorsiflexion of foot and extension of the great toe. Great toe will be gone. There is no particular reflex associated with L5, but with L4 you will have a loss of patellar reflex. So they can ask you this also. So you can easily understand. First try to find which is paracentral or central. If paracentral, lower root is involved. If central, lateral, upper root is involved. And similarly you can see the sensory motor and the reflex which is gone. So you can easily understand. This I have told you. I have told you this. Now, yes, there is a question. A 45-year-old male, paracentral disc prolapse L4, L5. So L4, L5 paracentral, that means which will be gone? L5. तो L5 sensory supplies कहाँ की करता है? L5 supplies to the lateral leg. तो sensory supply of the lateral leg and dorsal will be gone, and it supplies motor supply to the for the extension of the great toe and dorsiflexion of the ankle. So extension of great toe and dorsiflexion of the ankle will be gone. Well, there will be patella reflex. No, it is gone in L4. Weakness in the toe extension and ankle dorsiflexion. Yeah, this is the answer. Okay. So this is how they can ask you question. Which of the following can lead to synovitis of hip joint? Hip joint की synovitis कौन कर सकता है? Now, there is very important point. There are three important points which I am telling. If you know these points, you can solve a lot of MCQ regarding the hip joint and even in pediatric. Whenever a patient present you with abduction and ABD means abduction and external rotation at hip joint, there can be two possibilities. One, it can have anterior dislocation, which is very rare. Anterior dislocation of shoulder is common, but posterior dislocation of hip is common. And second, it can have synovitis. It can have synovitis. Now, what can be the causes of synovitis? Synovitis causes can be three. It can be because of TB. It can be because of septic arthritis, and it can be because of Perthes disease. Okay. Now, there are three points regarding septic arthritis. There have been three questions which have been asked. Most common age of septic arthritis is 2 to 5 years. Please remember, most common age of septic arthritis is 2 to 5 years. Then, most common side, it is the femoral head. It is the femoral head. Most common side, it is the femoral head. And if septic arthritis occurs below 1 years of age, that is infantile septic arthritis, what it is known as? It is known as Tom Smith arthritis. Tom Smith arthritis. So these are the three questions which has been asked. Most common age, most common site, and if what is infantile septic arthritis has. Now regarding Perthes disease. Perthes disease is basically osteochondritis of femoral head. It is osteochondritis of the femoral. Now, if I ask you Perthes disease, we all know most common age of presentation of Perthes disease is 4 to 8 years. 4 to 8 years. Now, what is the presentation? So initially the presentation as we are seeing is abduction and external rotation. Abduction and external rotation. But once the necrosis starts, what happens is there is adduction and external rotation. Adduction and external rotation. And then during the phase of healing, there will be abduction and internal rotation. So what you are seeing, Perthes disease can have different types of, it can be abduction, external rotation, adduction, external rotation. Now what happens is slipped capital, if we see SCFE, slipped capital femoral epiphysis. What is the presentation? Presentation of slip is adduction and external rotation. Now, so just on the basis of presentation, you cannot differentiate Perthes disease with SCFE, because although SCFE has adduction external rotation and same on the necrosis phase, Perthes also has adduction external rotation. So how will you differentiate Perthes and SCFE? The main thing is the age. SCFE occurs at 10 to 15 years of age, whereas Perthes occur at 4 to 8 years of the age. Please remember this thing. Also, SCFE will have a history of acute to subacute trauma. acute to subacute trauma. But Perthes has an what? It has an insidious onset. That means slow onset, intermittent pain. Sometime pain will be present and then it will be gone. It will be very insidious, not very acute. So with the help of these, all the yes, we can diagnose with the help of X-ray, but just on the basis of presentation, that abduction externalization, you cannot differentiate between Perthes disease and SCFE. This is what I wanted to explain to you. That's why I have especially incorporated this thing. Okay. During the phase of necrosis, SCFE and Perthes disease has the same presentation, that is adduction and external rotation. This is what I wanted to tell you. Now about TB, I have told you in TB, I have told you stage 1 is synovitis. So only in TB you have to remember two things. I have TB stage 1 is synovitis. Stage 1 is synovitis and it presents with adduction and external rotation. But from stage 2, 3 and 4, it will, in all these stages, it will present with adduction and internal rotation. So because only TB stage 1 will present with the abduction external rotation, but in stage 2, 3 and 4 it will present as adduction and internal rotation. Adduction and internal rotation. The most common site involved by the TB is, answer is acetabulum. Acetabulum. It is just, in septic arthritis most common is femoral head, and in TB it is the acetabulum. Both has been asked. Okay. So TB stage 1 is synovitis present with abduction and external rotation, and in stage 2, 3 and 4 it will present as adduction and internal rotation. Stage 2 is called as periarticular osteopenia. Stage 3, there is decreased joint space. And in stage 4, there will be wandering acetabulum. Wandering acetabulum. This has been asked a lot of times. Okay. This is known as early arthritis. It is known as late arthritis. This is known as advanced arthritis. So stage 1 is synovitis TB. Stage 2 is early arthritis. Stage 3 is late arthritis. And stage 4 is advanced arthritis. So this has been asked. So wandering acetabulum has been asked a lot of time. That wandering acetabulum is seen in which stage of the TB? Stage 4. What will be the presentation? Adduction and internal rotation. Abduction and external rotation will be seen only in the stage of synovitis, that is stage 1 of the TB. So you have to remember this thing. Okay. So what they are asking, which of the following can lead to synovitis? So I have told you synovitis can be seen in the TB of the hip. Yes. Perthes disease, septic arthritis. Yes. All of the above. So you have to remember this chart. If you remember this chart, you can solve all the questions. Okay. Now, whenever you have abduction and external rotation, I have told you, it can be anterior dislocation, it can be synovitis, and synovitis can be because of TB stage 1, it can be septic arthritis and Perthes disease. Perthes disease, septic arthritis, most common age 2 to 5 years, most common site femoral head. If less than 1 year, Tom Smith arthritis. Perthes disease, I have told, it can have abduction, external rotation, adduction, external rotation, and during healing phase this, and during necrosis phase, the adduction, external rotation is just like SCFE. I have told you this. So just on the basis of presentation, we cannot differentiate SCFE and Perthes disease. So how to differentiate? SCFE, the age is 10 to 15 years, and Perthes 4 to 8 years. Acute trauma, and Perthes disease insidious onset. Okay. Perthes disease, avascular necrosis. Perthes disease, please remember, very important point. This was asked in USMLE. P for Perthes, please remember, passive smoking. Passive smoking is a risk factor for Perthes disease. Also coagulopathy and collagenopathy. problem related to collagen, coagulopathy, and low socio-economic status. So whenever these things are given in the uh, whenever age is 4 to 8 years, insidious onset, intermittent pain, they are giving passive smoking. This was asked in USMD. Passive smoking is given coagulopathy, collagenopathy, or low socioeconomic status. These diseases will be answered. Whenever they give acute trauma, and this is slip capital femoral epiphysis will be answered. I told you TB, most common site estabulum. Stage 1, it show abduction, external rotation, synovitis. Stage 2, 3, 4. All will have adduction and internal rotation. Stage 2 is early arthritis, periarticular osteopenia. Stage 3 is late arthritis. There will be decreased intraarticular space. Stage 4 is advanced arthritis, that is wandering scapula. Everything has been explained. Which part of the hip joint is primarily affected in TB? Acetabulum. Femoral head is involved in septic arthritis. Okay. Name the sign. Yes. Can anybody tell me the name the sign? See, we can see that there is a problem on the left side. This is your acetabulum. This is femoral. Now, this lower part of the acetabulum is empty. Okay, and femoral head has come slightly to the this side. So whenever the lower part of the acetabulum is empty and femoral head has moved toward the lateral and the posterior side, this is what is called as wandering acetabulum. This is known as wandering acetabulum. The lower glenoid cavity, lower acetabulum is empty, and uh, femoral head has moved slightly lateral and posterior. This is called as wandering acetabulum, seen in stage 4 of TB. What will be the presentation of patient at this time? Adduction and internal rotation. So it is a wandering acetabulum. Lower acetabulum is empty. So empty is seen is same. It is fourth of the TB. Now identify this side. Can anybody identify it? Now normally what happens if this is the acetabulum and this is the femoral head, and you draw a line from, and this is femoral neck. If you draw a line from the superior surface of the femoral neck, it will hit the femoral head, and this line is known as Klein line. This is known as Klein line, Kline, Klein line. But if this Klein line that is drawn from the superior surface of the femoral neck does not hit, for example, if it goes like this, here see, it is, if we are drawing a line from the superior surface of the femoral neck, it is not hitting the head of the femur. Then then it is known as Trethovan sign. Trethovan sign. This is known as Trethovan sign, and this is diagnostic of SCFE, slit capital femoral epiphysis. This is Trethovan sign when the line drawn from the superior surface of the femoral neck does not hit the femoral head. That is called as Trethovan sign seamless. Now also, if you draw from the if you draw a line in the femoral head from the acetabulum, there will be a break in the line. Normally, if you draw a line from the acetabulum, it will comes to the femoral neck and then to the shaft of femur. There will be no break, but here there will be a break. This is known as S sign. Although I am showing it in AP view, but the best view to see S sign is frog view. Best view to see S sign is frog view. It is also seen in SCFE. So these are the true point. Normally clean line, absence of clean line to intersect at femoral head is known as Stratholon sign, and S sign in frog view. This is seen in case of SCFE. So this is one of the way. Can anybody tell me what kind of Salter-Harris classification slipped capital femoral epiphysis comes in what kind of Salter-Harris classification? Although I will teach you Salter-Harris classification, it is type 1. It is type 1. It is type 1 Salter-Harris classification. Okay. So this is the K line, which normally hits the femoral head from superior surface of the femoral neck and meet femoral head. This is the acetabulum, this femoral head. In SCFE, this clean line does not meet femoral head, which is known as Trichovan sign. S sign. If continue lower acetabulum, if a line is drawn from the lower acetabulum and femoral neck, there will be a break in the line known as S sign, and it is best seen in the frog view. Best seen in the frog view, not best seen in the AP. Okay. Now this match the column osteochondritis. Now here you have there are tongue twisting name. Patella. What is the osteochondritis of patella is known as? It is known as SLJ syndrome. That is first is D. What is SJ? Sending S for is sending Larson Johansson disease. Sending Larson. You write singing and remove G D and write in place of G write D. That is Sending Larson Johnson syndrome. Tibial tuberosity. What is known as? That is known as Osgood SCH Latter syndrome. Osgood Slatter syndrome. A. Second metatarsal. It is Freiberg disease. Fifth metatarsal. Island disease. So it is first D. So what is the answer? Match the columns. I have told you. So ठीक है. So this I have told you. Answer is A. Answer push. Okay. Now you have to remember. I am telling you a lot of osteochondritis. Please remember them. See my drawing. Just bear it. Very beautiful. I'm a very good artist. Now, in the upper limb, you have to remember three osteochondritis. One, there is a capitulum bone, capitulum. Capitulum is a part of humerus. It is present in the anterior part or posterior surface. It is anterior surface. It is present medially or laterally? Laterally, because medially propria is present. Then you have to remember lunate bone, and you have to remember scaphoid. So, capitulum osteochondritis of capitulum is known as. Can anybody tell me? Can anybody tell me what is the? It is known as Panner's disease. Panner's disease. This is known as Panner's disease. Osteochondritis of lunate is known as KEIN, Kienbock disease. Kienbock disease. Osteochondritis of scaphoid is known as PREISSER, single S, Pries's disease. Pries's disease. So you have to remember them. Then here is the vertebra. Vertebra. That is known as Scheuermann disease. SCHEURMAN. You don't need to remember the spelling. Just remember Scheuermann. But exact spelling is this. Because I have to write, so I have to remember it. Now here you have to remember two. One is patella and other is tibial tuberosity. Tibial tuberosity, it is Osgood Schlatter, Osgood Schlatter disease. Patella, I've told you it is SNJ disease. What is S? S is for Sending Larsen Johansson disease. Okay. Then we have second metatarsal. Second metatarsal, and we have fifth metatarsal. Second metatarsal, what is known? It is known as Freiberg disease. Freiberg disease. Osteochondritis of second metatarsal is known as Freiberg disease. Osteochondritis of fifth metatarsal. In this S is silent, so this is known as island disease. Island disease. ISELIN disease. S is silent. Now, what is the osteochondritis of navicular bone? It is Bohler's disease. Bohler's disease. Asked a lot of time. Osteochondritis of navicular is Bohler's. Osteochondritis of calcaneum. 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 Is it visible? Calcaneum. It is known as severe disease. Severe disease. It is severe disease. It is very severe. Navicular Bohler. So you have to remember these osteochondritis. Okay. Now let's revise them. Lunate Kienbaum scaphoid creases. I said not single S है. Capitulum planus disease. Vertebra Schurman disease. Patella Sinding Larsen Johnson. Sinding Larsen Johnson. SNJ. Tibial tuberosity Osgood Schlatter syndrome. Second metatarsal Freiberg. Fifth is eyelid. S is silent. Okay. Teasers में there is single S and eyelid S is silent. Navicular Bohler. Calcaneum severe disease. So you have to remember. There are it's a very high yielding topic because people generally forget it. So make a chart and remember it daily. Now next question. Now 82-year-old male has a hip injury after the fall and he develops IT fractures. You have given the diagnosis. Which is most accurate? It is predominantly occurs in female and less likely to result. So first we have to understand what is a intertrochanteric fracture. Okay. So basically remember the difference between femoral neck fracture. Okay. So we have femoral neck fracture and we have intertrochanteric fracture. So I'm telling you a very important technique, just a very story. Please remember this is inter. If a boy is studying inter, generally you will not see that boy in the school or beside the class. Mostly you will see that boy outside the class, that is external in the external areas. You will not see that boy out inside the class. Okay. And when he will be outside the class, he will be a pain in the ass to most of the people. He will do all sort of bad things. He will give pain to his grandfathers, uncle, and everyone. So he will be a pain in the ass to the other people. And when that boy will not be inside the class, what will happen to his attendance? Attendance will be short. There will be very short attendance. Okay, so what I've told you that if a boy is studying in inter, most of the if this is his school, most of the time he will be outside. That is, he will be external. He will be most of the time he will be outside, and he will be a pain in the ass. Sorry, I'm writing this because my just motive is to that you people remember. To most of the people, and the attendance will be short. So if you remember this story, you can remember everything regarding intertrochanteric fracture. First thing, from this external, you can remember it is extra capsular. It is extra capsular. External rotation is very much, that is more than 45 degree. External rotation is more than 45 degree. Extra cap. Pain will be very much. Attendance will be short. That means shortening will be very large. So there will be too much shortening. Okay. So this is how you. So it will be an extracapsular fracture, whereas femoral length will be intracapsular. External rotation will be more, that is more than 45 degree. Here external rotation will be less than 45 degree. Here the pain is very large, pain will be less. Short, if attendance is short, the shortening is very very large, there will be low shortening will be less shortening. So just by this story you can remember. And very important, right? Since intertrochanteric fracture is any fracture between the greater trochanter and lesser trochanter, it is a metaphyseal fracture. And any metaphyseal fracture has a tendency to grow very fast. So that will join. So if you will not treat it properly, that will go into the malunion. So intertrochanteric fracture, most common complication will be malunion. It will be malunion. Just like supracondylar fracture. What is the most common complication? Malunion, because it is a metaphyseal fracture. Okay, what is the most common complication of lateral epicondyle? Non-union. Scaphoid? Non-union. What is the most common complication of femoral neck? Avascular necrosis. Avascular necrosis followed by non-union. Just opposite to scaphoid. In scaphoid, most common complication is non-union followed by avascular necrosis. And in femoral neck, most common complication is avascular necrosis followed by. And femoral neck fracture is a fracture of necessity. Okay. So now if we go into this question, what we'll see first, which is accurate. Intertrochanteric fracture predominantly occurs in female. No, it occurs in the male and less likely to result in malunion. I have just told you it is a metaphyseal fracture, so it will go into the malunion. So this is wrong. Second, both IT fracture and femoral neck fracture equally result in non-union. No, but IT fracture typically present with less pain. It has a more pain because that boy is a pain in the ass to the other people because he's going outside and he's giving pain to other people. And greater internal rotation. No, IT fracture has a more external rotation, more external rotation and extracapsular. So external you have to remember. IT fracture are classified as extracapsular, yes. Why? Because the guy is outside the class, extra. While femoral leg are intracapsular. IT fracture present with significant shortening and increased DI. Yes, this is the answer. Okay. IT fracture are intracapsular, galat ho gaya. Okay, so this you have to remember. What is treatment of choice in IT fracture? IT fracture, what will be the treatment? It will be what? Dynamic hip screws. So it is IT fractures are because metaphyseal fractures, they will join very easily. You have to just use DHS, that is dynamic hip screws. Dynamic hip screws. Answer will be C. Dynamic hip. Metaphyseal will not dynamic hip screws. Now, in the management of active patient with a displaced femoral neck, which of the following considered most appropriate? So now I'll tell you what is the treatment of femoral neck. Femoral neck is a fracture of necessity. And I have told you that, I have told you 6 fracture of necessity. I have told you that whenever they will give you the treatment for those fracture of necessity, 6 fracture, conservative management will never be the answer. So you can never have conservative management for femoral neck fracture. What were those 6 fracture? They were lateral epicondyle of humerus, They were fracture femoral neck, Montagia, Galegia, intra-articular fracture of radius, that is Barton fracture, and parts apart fracture of olecranon process and patella. Okay, I'm again repeating, although I have told this in my first video. It is lateral epicondyle fracture, then it is uh, femoral neck fracture, fracture Galegia, fracture Montagia, then part apart fracture of the patella and olecranon process, and Barton fracture, that is intra-articular fracture of the radius. In these fractures, you can never have conservative measurement. So I'm telling you, femoral neck fracture, femoral neck fracture management. First thing is age. You have to see age is less than 65 years, age more than 65 years. Age is less than 65 or more than 65. If the age is less than 60, if age is more than 65 years, you have to see whether the patient has arthritis or not. If arthritis is present, you have to go for total hip replacement. You have to go for the total hip replacement. If arthritis is absent, you have to go for any arthro plus. You have to just change the femoral head. If it is less than 65 years, you have to see timing. Less than 3 weeks, more than 3 weeks. Because you know that basic aim is to present the femoral, preserve the femoral head. Now I've told you femoral neck is a fracture of necessity. So there is no no conservative management. No conservative management. If it is less than 3 weeks, you can very well use cancellous cannulated screw. If it is more than 3 weeks, then you have to give a blood supply. So what kind of graft you will take? You will take Mears graft. What is Mears graft? It is Mears graft. Which muscle is taken? Quadriceps femoris. Mears graft. So this you have to remember. This is the treatment of femoral fracture. Now so they are asking displaced fracture age they haven't told you. ठीक है पिनिंग विनिंग होती नहीं है ठीक है so they have asked in the management of active displaced fracture active patient है young patient है इसका मतलब फिर displaced femoral neck fracture which of the following ठीक है तो THR भी नहीं होगा ठीक है which of the following is most open reaction under cannulated screw this will be the answer okay why conservative management भाई होता नहीं percutaneous spinning होता नहीं है टोटल हिप रिप्लेसमेंट हम तब करते हैं जब 65 साल से ज्यादा हो आदमी और दोनों वो पता है नहीं तो अच्छा वो आंसर क्या है कैंसर दिस इज व्हाट यू हैव दिस आई हैव टोल्ड यू भाई मेयर ग्राफ quadriceps femoris now can anybody can anybody can anybody tell me what is this fracture anyway I will help you see this is ulna this is radius so there is a fracture of proximal ulna plus radial head dislocation. Radial head dislocation, proximal. Here what you are seeing? Distal radial fracture. Distal radius fracture and radio ulnar dislocation. What is there? Here you are seeing radio ulnar dislocation rupture of interosseous, sorry, rupture of interosseous membrane and radial head fracture. Now, can you tell me what is this? So now this is the basically fracture montagia. This is the fracture Galeazzi, and this is fracture Essex low presti. Essex low presti. E double S E X सेक्स के पहले ES लगा दो. Essex low presti. LOPRESTI. Essex low presti. Essex low presti. So Montagia, I have told you, M for medial. If there is a medial that is proximal ulnar fracture with radial head dislocation, that is Montagia. Which is the most common nerve involved? It is the posterior interosseous nerve involved. It is a branch of radial nerve. Okay, what is Galegia? Galegia, I have told you, can remember by the frog. That is fracture radius. So if there is a fracture of the distal end of the radius along with the radial dislocation, that is Galegia. And in Essex low presti, when you fall like this, so there will be a transferred fracture. That is a fracture. The force will be transferred to the radius head. So there will be fracture of the radius head, disruption of the interosseous membrane, and radioulnar dislocation. So in Essex low presti fracture, you have three things: radial head fracture, disruption of interosseous membrane, and radioulnar dislocation. So please remember these fractures, they can be asked. It's very high chance. Okay. So I've told you Montagia, Galegia, and Essex low presti fracture. The important name upper limb fracture. So I've told you, if this is your upper limb, some name fractures you have to remember. There is a Barton fracture. There is a Schoffer's fracture. Everybody knows what is a Smith fracture, Oley's fracture. These all occur here. What is Barton fracture? It is intra-articular radius fracture. Intra-articular radius fracture. Okay. Schoffer's is styloid process fracture. Styloid process of radius fracture. I have shown this fracture in my first video. Smith fracture is extra-articular fracture of radius. Extra-articular fracture of radius where the distal fragment moves volar. That means, for example, if this is the fracture, distal portion will come anteriorly, that is towards volar part, towards palm area. And if the distal fragment goes dorsally, then it will be called as Colles fracture. Colles is also extra-articular fracture radius head, but here the distal end will move posteriorly. So what kind of deformity in Colles fracture you see? Dining fork deformity. And in Smith fracture you see garden spade deformity. Garden spade deformity. Okay, this you have to remember. These are the. Then I have told you there are in the first metatarsal. If there is base fracture of the first metatarsal, that is known as Bennett fracture. But if there are three or more fragments, then it will be called as Rolando fracture. And I've told you Rolando fracture and Bennett fracture, which is the muscle which will pull the first metaphysis. It is abductor pollicis longus. And I've told you three questions related to abductor pollicis longus. Abductor pollicis longus and extensor pollicis brevis. Inflammation is called as decurvent tenosynovitis. And the test is ECOF test and Finkelstein test and abductor pollicis longus. Can you tell me abductor pollicis longus is supplied by which nerve? It is supplied by the radial nerve. And abductor pollicis brevis, it is supplied by the medial. Very good. So I have told you all the tests and everything there. So these are the tests. Then there is very important fracture, that is boxer fracture. What is the boxer fracture? It is the fracture of the fifth metatarsal. Fifth metacarpal. Sorry, I told tarsal. So boxer is the fifth metacarpal fracture. Okay, boxer fracture. Because generally when boxers are not very much trained, there is slightly movement of hand like this, and this area is gone. So there is a fracture of the fifth metacarpal. Now, what is the fracture of fifth metatarsal? Fifth metatarsal. Can anybody tell me? That is known as Jones fracture. Okay, fifth metacarpal, fifth metatarsal. That is Jones fracture. Okay, so you have to know these fractures. Plus, I have already told you Essex-Low-Prestige and fracture, Galeazzi and Montague. So I have told you boxers, Ronaldo, Bennett. What is mallet fracture? Mallet fracture is, for example, if this is your finger, it has a what? It has a PIT, proximal interphalangeal joint, and distal. If this is the distal phalanx, so the extensor tendon which comes to the distal base of the distal phalanx, there is avulsion, there is rupture. So there is avulsion or the rupture of the external extensor tendon at the base of the distal phalanx. So what happened? It is like this. So there is a flexion at the DIP, distal interphalangeal joint. This is known as mallet finger. So mallet finger, there is flexion at the distal interphalangeal joint because of avulsion of the extensor tendon at the base of the distal phalanx. Then I have told you what is Smith, Colles, Barton, and Schoffer's fractures. Essex, Lopresti, Galegia, Montagia fracture. I have told you these things. Now identify this fracture. Identify this fracture. Can you tell me? Now, whenever you count this, count it as a 1, 2. This is 1, this is 2. This is 3, 4, 5, 6, and 7. So this is the C7 fracture. And this is the spinous process. So it is a fracture of spinous process of C7. And this is known as which fracture? This is known as Clay Shawler fracture. This is known as Clay Shawler fracture. Oh, Clay Shawler fracture. K Shawler fracture. That is the fracture of the spinous process of the not transverse process, the spinous process of the C7 vertebra. So this is a Clay Shawler fracture. What is this fracture? Now this is the vertebral body. This is the pedicel. So fracture has involved the pedicel, then posterior part of the vertebral body and anterior, and it is transverse. So this fracture involve the vertebra, what? Pedicel and vertebral body, posterior surface as well as anterior surface, and it is a transverse fracture. It is a transverse fracture. This fracture is known as chance fracture. Chance fracture. This is also seen commonly in case of seat belt injury. Seat belt injury. This is a chance fracture. Seat in case of seat belt. Now, what is this? Yes, this is known as whiplash fracture. Whiplash Flash fracture. What happened? It is sudden extension followed by sudden flexion. Sudden extension followed by sudden flexion. Now can ask you what is whiplash fracture. There is sudden extension followed by the sudden flexion. One thing that they can ask you is which is the what is the structure which is gone in this? Answer will be ALL, that is anterior longitudinal ligament. Okay, so most commonly affected area is ALL, that is anterior longitudinal ligament. Okay. Now C1 fracture of C1 I already told you that is Jefferson fracture. Jefferson fracture. Where I told you C2 fracture is known as hangman fracture. There I also told you that C1 fracture is known as Jefferson fracture. So C7 is Clay-Shawler fracture. Chance involves pedicel. Chance involves pedicel transverse fracture of vertebral body from posterior to anterior substance. Whiplash injury extensor followed by flexion injury occurs to ALLL. C1 fracture. Now identify the type of Salter-Harris classification. Just give me 1 minute. वहां पे लगा दो. हाँ. ले जाए कर. So identify the type of Salter-Harris classification. So before understanding, let's teach you what is Salter-Harris classification. Salter-Harris classification is used for the physical injury or growth plate injury. For example, so you can remember it like this. If this is your bone and this is the growth plate, this is diaphysis, this is diaphysis, this is metaphysis, this is physis or growth plate, and this is epiphysis. Okay, now write down Salter, Salter. Write one bit below A, S, write 2 here, write 3 here, write 4 here, and write 5. So from S, remember straight. So if the fracture is it is straight along the growth plate, that is known as Salter-Harris type 1. If the fracture is along the growth, if the fracture is along the growth plate, if the fracture is along the growth plate, that is called as Salter-Harris type 1. And so what is the example? Example is SCFE, slip capital femoral epiphysis. Okay. Now, A for above. If the fracture line moves above the physis, that is, for example, if the fracture comes here and then it moves like this, that is A for above the growth plate, then it is a type 2. Okay, now very important point. In type 2, this is the after fracture, you will see this, and the shaft will be like this. So triangular portion of the shaft will be attached to the growth plate. So in type 2 Salter-Harris classification, after the fracture, a triangular portion of the shaft, this area, this triangular area, will be attached to the physis. So this is a characteristic feature of the type 2 Salter-Harris classification, that a triangular portion of the shaft will be attached to the growth plate. And what is the example? Example is Supracondylar fracture. Supracondylar fracture. Okay, supracondylar fracture. Now L is for A is for above, L is for low. That is below. Okay. So if the fracture is like this and it comes below like this area, then it will be type 3. That is in type 3, the fracture will be along the physis and then it will enter into the epiphysis. So if it involves the epiphysis, it is 3. What is the example? Example is Telok's fracture. Telok's fracture. What is Telok's fracture? Telok's fracture. This is just the example of actually this is tibia. This is the growth plate. Now the fraction has involved the growth plate and it comes below. So this area, you see, this is the distal end of the tibia and this is Salter-Harris type 3 classification. So Telok's fracture is basically distal tibial fracture in children, and it is the Salter-Harris type 3. This is a Telok's fracture. Telok's fracture. Okay, so this is what Telok's fracture. Now what happened for T means through. If the injury occurs through the growth plate, that is means metaphysis, growth plate and epiphysis, both all three are involved. Metaphysis, epiphysis and growth plate. It is called as type 4 and the example is lateral epicondyle. Lateral epicondyle. Lateral epicondyle fracture is 4. And fifth is if there is a crushing injury, that is whole growth plate is destroyed. That is a crushed injury. That is whole growth plate is destroyed after a fall. That is seen case of after a fall. So you have to remember, identify it, plus you have to know the examples of Salter-Harris classification. Okay. So this is a Telok's fracture, very important. I have told you this very important. Identify the given pictures and answer. So what I have just told you, this is fibula, this is tibia, and this is Salter-Harris type 3 classification. This is Telok's fracture. Which fracture? This is Telok's fracture. Now, this is tibia. This is calcaneum. Which bone is this? This is talus. And talus, please remember, this is the head, this is the body, and this is the neck. So this is the it is a, although it has been written talus neck fracture. This is a talus neck fracture. What is this known as? Can maybe tell me? What is this fracture known as? Talus neck fracture. This is known as aviator fracture. This is known as aviator fracture. So talus neck fracture is known as aviator fracture. It is known as aviator fracture. What is this fracture? This is again, this is fibula, this is tibia. You are seeing this is articulating surface of tibia, this is talus. So there are multiple fracture. So this is fracture distal tibia with of articular surface and it is comminuted fracture. COMMINUTED. Comminuted fracture. This fracture is known as pylon fracture. Pylon fracture. What is pylon fracture? Pylon fracture is the fracture of distal tibia intra-articular comminuted fracture into various fragments. What is comminuted fracture? When the fragment has more than 3 or more fragments. That is called as comminuted fracture. And please remember, in more than 95% of cases in pylon fracture, there is also fibula fracture. So this is called as a pylon fracture. Now, identify the ligament. This are metatarsal bone. This is what bone? This is cuneiform. This is cuboid bone. cuboid. Cuboid is attached to calcaneum here. This is navicular and this is cuneiform. Medial cuneiform, middle cuneiform and lateral cuneiform. So please remember, from the middle cuneiform to the second metatarsal, there is a very important ligament that has been asked several times. This is known as Lis-Frank ligament. Lis-Frank ligament. This is very much important for the stability of tarso-metatarsal joint. Okay, Lis-Frank ligament. If there is any injury in the base of the second metatarsal, or if there is dislocation of the second metatarsal over cuboid, then this ligament get ruptured. So any fracture dislocation through tarso-metatarsal joint. Okay, this is what? This is tarso-metatarsal joint. Any fracture or dislocation through tarso-metatarsal joint is known as Lis-Frank fracture. I'm writing here, is known as Lis-Frank fracture. Lis-Frank fracture dislocation. So any fracture dislocation which occurs through the tarso-metatarsal joint is Lis-Frank fracture. Any fracture dislocation which occurs through intertarsal joint. That is, there are 7 tarsal bones. First is medial cuneiform, middle cuneiform, lateral cuneiform, cuboid, then calcaneum, navicular, and talus. If there is any fracture dislocation inside the intertarsal joint, that is called as chopard fracture. Chopard fracture. So you have to just remember 2 lines. Any fracture dislocation through tarso-metatarsal joint, that is called as Lis-Frank fracture. Any fracture dislocation through intertarsal joint, that is known as chopard fracture. For example, this is this is second metatarsal, this is medial cuneiform. So there is fracture of second metatarsal and dislocation. So this is fracture dislocation through tarsal metatarsal. So this will be known as Lis-Frank fracture. This will be known as Lis-Frank fracture dislocation. Okay, this is very important. Now here you see this is cuboid bone. Cuboid bone fracture. Here there is a talus fracture. Talus is attached to which bone? Navicular. So navicular dislocation. So what we are, these all are talus bone. So what you are seeing fracture dislocation through intertarsal bone. So that this will be called as chopard fracture dislocation. I'm just again repeating. Any fracture dislocation through metatarsal joint is Lis-Frank fracture. Any fracture dislocation through intertarsal joint like this is known as chopard fracture. Okay. This is the fracture of the 5th metatarsal. I have told you this is Jones fracture. I have told you this Salter, Tillox, Aviator, Hylon, Lis-Frank. That is dislocation of second metatarsal over middle cuneiform plus second one. I have told you this already. Okay? Fracture 5th metatarsal known as Jones fracture. And 5th metacarpal boxes fracture. Now comes to the CTEV, congenital talus equinovarus. There are tricky questions which are asked from CTEV. So what happened? What are the deformities in CTEV? Deformities are C, then A, then V, then E. What is C? C is cavus. Cavus means what happened? This is a normal medial arch of a person like you and me. There is exaggerated or heightened medial arch, just like a cave you see. So this is what is called as the cavus deformity. So what is cavus deformity? Exaggerated medial arch. It is exaggerated medial arch. A for there is adduction. This is the left leg. This is the end. You are seeing from anterior. So what happened? There is adduction. There is adduction. Then there is a varus. Varus means it is internally rotated. Now very important. And then third is equinus. Equinus means normally what happened? We, if this is our heel, we touch calcaneum, that is we stand like this. But in CTEV patient, what happened? Calcaneum cannot touch the heel. So what happened? Patient is like this. Calcaneum is not touching the heel. So this is called as plantar flexion. So the foot is present in plantar flexion. Okay. So foot is fixed in plantar flexion because it is like this. It is fixed in plantar flexion. Now they can ask these things, but most important things they will ask you which joint is involved in where that is internal rotation. Talonavicular joint is involved. Talonavicular joint is involved in cases of the varus, and in cases of adducts, tarso metatarsal joint are involved. Metatarsal joint are involved. Okay. So these are the deformity. So how will you diagnose the patient? You can diagnose the patient just at the time of birth. Normally, if this is the anterior surface of the leg and this is the dorsum. So in newborn baby, this dorsum can touch the anterior surface of the leg. But in case of CTEV, you will not be able to you will not able to touch the dorsum to the anterior surface of the leg. So this is one way of making the diagnosis. Okay, secondly, every 24th week of the ultrasound, you can also make the diagnosis prenatally, and after birth, you can make just by this test. So basically, they ask question regarding the treatment. So what is the treatment? Earlier there was a French method, then there was a kites method. Radiologically, you can also diagnose. There is a angle that is known as kites angle. I had taught that angle normal in my first video. Normal value is 25 to 40 degree. If it is less than 25 degree, that is called as varus. So that is also a way to diagnose. Okay. If it is more than 40, that is valgus. So in CTE, we get this kite angle less than 25 degree. So there was French method, there was kite method, and these both methods are not used now. Which method we use? We use Ponseti method. What happened in this? It is used if the child, if we diagnose it at the birth or after birth, that is before 1 year. What happened? We fix the deformity in this order. First the cavus is taken care of, then adduction and varus is taken off, and then equinus deformity. If there was a question which was asked, which of these deformities is most difficult to treat? So answer will be equinus. Equinus is most difficult to treat. Okay, so this is the order in case of Ponseti method. First we treat cavus, then we treat adduction and varus. Adduction and varus is clubbed together, and then equinus. So what happened is that first we put a plaster to the baby, then for cavus, then after 2 to 4 weeks we again put a plaster to correct this deformity, then again after 2 to 4 weeks we put a plaster to treat this equinus deformity. So series of plaster are put, and after that what is baby is given is splint, that is Dennis Brown splint, Dennis Brown splint, and baby has to wear this Dennis Brown splint 24 hours till 1 year, because after 1 year baby start walking. So what you have to do now, in the night time baby can wear the Danish brown splint, but in the daytime they are specially made CTEV shoes, specially made CTEV shoes. The important point regarding these CTEV shoes are these are flat sole. They have a flat sole. They have flat sole, but the lateral border lateral border are raised. They have flat sole but lateral borders are raised. So this you have to do after 1 year. So initially you will treat these deformities, that is cavus, adduction, varus and equinus, through a series of plaster, and then you will give Dennis Brown splint which the baby has to wear 24 hours till 1 year. And then after 1 year when the baby starts walking, in the night you will give Dennis Brown splint and in the day you will give CT shoes. Now if the baby is if it is diagnosed after 1 year but before 5 years, then you can do posterior medial release operation. Posterior medial release operations or surgery. So before 1 year you will not do. If you will do posterior medial release operation, that you can do. Okay. After 5 years, less than 10 years, you can do osteotomy. Osteotomy. You can go for the osteotomy. And after 10 years, you have to go for triple arthrosis. Triple arthrosis. So you have to join 3 joints. How can you remember? Just remember by simple story. Which are the 3 joints? You went in a train and TC came. TC asked for your ticket, but you were not having a ticket. So your ride was cancelled. So TC came to take the ticket and your ride was cancelled because ticket was not there. Okay, so tallow calcaneal joint, sorry, just because of that. Triple arthrosis involves 3 joints. These are, yes, TC, TC Ames and ticket was not there, so cancel. These are the 3 joints. That is tallow, this is tallow navicular joint. Suddenly it has gone out of my mind. This is calcaneo cuboidal joint. And tallow calcaneal joint. Okay, so these are the 3 joints. Tallow calcaneal. So you go through this like this. This is the talus bone, tallow navicular, because navicular, then tallow calcaneal, and then calcaneo cuboidal. So these are the 3 joints. So perfectly fine. Okay. So they can ask you in triple arthrosis, this joint is not involved. Okay. So tallow calcaneal, tallow navicular, and calcaneo cuboidal joint. These joints are involved. And 5 to 10 years osteotomy. Once they have asked you the name of the osteotomy, you can remember it: LICHT, Lich Lichblau osteotomy. All you can also go for Evans osteotomy. Okay, you can also go for DWYER, wire osteotomy. So these are the three osteotomy that you can. You don't need to know the details of the osteotomy. Just you can also remember this Lichblau by Lick Blouse. If you remember Lick Blouse, you can easily solve the MCQ. Lick Blouse, Evans, and Wire. But the exact spelling is LICHTBL. Lick Blouse, Evans. And then there is a posteromedial release operations. Okay. So this is how you treat. This was regarding CTE, treatment of CTE. Name the traction shown. This is gallows traction. Gallows traction. It is used for femoral shaft fracture. Femoral shaft fracture in children less than 2 years, less than 15 kg. And this is a skin traction and overhead traction. So this is gallow traction, femoral head used in femoral shaft fracture, and battery is just 5%. Femoral shaft fracture. So that is a femoral shaft fracture. Okay, it is used for femoral shaft fracture. But what is this fracture? This is known as Buck's traction. It is a kind of skin traction. Skin traction. Now, please remember, it is used for short period of time. For example, if the patient is having femoral neck fracture, femoral shaft fracture, and is having a lot of pain, so the fracture is reduced, and this traction is given because it relieves the spasm of the muscles, reduces the pain, and it keeps the displaced. It does not allow the displaced factor. It keeps the displaced factor which we have reduced at its normal place. These are the two advantages. It reduces the pain and it does not allow the displacement of the fracture. Okay, so this is Buck's traction, but it is used for short period of time. If they ask you most common nerve which is injured during skin traction, answer is CPN, that is common peroneal. Now this traction, please, can anybody, what is this traction? Now this traction, this is like this. This is called as Bowler's stirrup. Bowler's stirrup. This is like this. Then we can insert pin. This is called as Bowler's stirrup. Okay, this is Bowler's stirrup. Now you can insert two type of pin. One is STEIN, steam man pin. Second is Denham's. Denham's. Please remember, Denham is serrated. Serrations are present, and steam man serrations are not present. No, so this is called as Bowler stirrup with Steinman or Denham pin. Now, what is this? These three pulleys. This is bowler's frame. Bowler's frame. This is bowler's frame. Okay. What is this? This is Barton traction. Why it is used? It is used in cases of cervical injuries, cervical fracture. For example, if a patient has cervical fracture, so this is inserted into the skull. It goes into the skull, and this part goes posteriorly. and when the patient is lying supine, and some weight is then attached to it, and then surgery is done. And once the cervical is fixed, this is removed. This is Barton fracture used in cervical fracture. Okay, C1 to C7 fracture. During surgery, can be used, or pre-operatively it can also be used. Okay, so I have told you this fracture. This is what is this? This is bowler's frame. Now there are three pulleys: first pulley, second pulley, and third pulley. The first pulley, this is not allowing legs to fall down. This pulley is giving traction to the your femur, and this is giving traction to the leg. So there are three pulleys. So this is bowler strip with uh, Steinman or Denhams. Okay. Now there is a question. Gaucher's disease caused by glucocerebrosidase deficiency primarily affect which part of the growth plate? Growth plate की किस part को affect करता है? So you have to know there are there is a if this is epiphysis, if this is your bone, this is growth plate. So from epiphysis towards metaphysis, if you go, so there are from epiphysis towards the metaphysis, there is zone of reserve cell. Then there is a zone of proliferation. Then there is zone of hypertrophy. Then there is zone of calcification, and then there is zone of ossification. These are the five zone of the growth plate when we go from epiphysis. Now, zone of reserve cell. This is destroyed in case of Gaucher disease. So in Gaucher disease, zone of reserve cell is destroyed. So answer will be reserve cell layer. Zone of proliferation will be affected in case of gigantism. That is when the person is very tall, so there will be very high proliferation, or dwarfism. Zone of hypertrophy. This is the weakest zone. Weakest zone. So zone of hypertrophy will be affected in case of the trauma. So in trauma, most commonly affected zone is calcification. This is affected in case of rickets. Ossification. This is affected in case of scurvy. So this all can be asked to growth plate layer. I have told you. Which is correct regarding bone marker? Alkaline phosphatase tells about bone resorption activity. No, alkaline phosphatase is a bone forming marker. So when bone formation increases, it tells it increases. So it is not a marker of bone resorption. Alkaline phosphatase is a marker of bone formation. This is wrong. Second, procollagen type 1C when are indicative of bone resorption. Again, this is for procollagen type 1N and 1C are indicative of bone formation, just like alkaline phosphatase. Osteocalcin produced by osteoblast is a marker of bone formation. Yes, osteocalcin is produced by osteoblast and it is a marker of bone formation. Acid phosphatase is a marker of ossifical fall. Acid phosphatase is a marker of bone resorption. Resorption. So it is a marker of osteoclastic activity, not osteoblastic activity. Now, so I'm telling you, uh, uh, there are this can be asked to you: bone formation marker or osteoblastic activity marker, and then bone resorption marker or osteoclastic activity marker. So there are three markers which tells you about bone formation. One is alkaline phosphatase. Alkaline phosphatase. Second is procollagen type 1N and 1C. And third is osteocalcin, which was asked, which was the right answer. And then bone resorption, there are 5 markers. One is acid phosphatase. The full name is tartrate resistant acid phosphatase. Tartrate resistant acid phosphatase. Second is hydroxylysine, hydroxyproline. Fourth is telopeptides. And last is very important. Please remember this because a lot of studies going on this. Deoxypyridinolines. Exact spelling. Deoxypyridinolines. This is a bone resorption marker. Lot of studies done on this. So they can ask about this. So this is a very important. Now this is a X-ray of the patient of scurvy. Now what is this? So I'm telling you, this is your this white line. This white line is known as white line of Frankel. White line of Frankel. And what does it show? It shows zone of provisional calcification. It shows zone of provisional calcification. This has been asked a lot of time. What is this spur like? This is called as Pelkan spur. Pelkan spur. Pelkan spur. What is this? This is periosteum. This is periosteum, and there is bleeding below the periosteum. This is called as subperiosteal bleeding. And cortex C, it is very thin. This is known as pencil thin cortex. Pencil thin. Now below this, the white line of Frankel, there is a radiolucent area. This is known as tremor filled zone, also known as scorbutic zone. And this ring is called as a ring epiphysis. This is known as Wim Burger's sign. Hamburger sign in seen in cases of osteopetrosis, and this is Wimberger sign. Wimberger. So you have to remember all these features, scorbutic zone, because they can ask you anything. So this is what we have to. Now, in cases of this was seen in scurvy, I have told you it's a periosteal bleed, scorbutic zone, tremor probability. Now, in rickets, wrist is the most common area where we see what is seen. There is concavity of epiphysis, concavity of the epiphysis. This is the earliest and the most specific finding, which is seen in cases of rickets. Plus, there will be small bones like fragments like this. This is known as fraying. This concavity of epiphysis is known as cupping. This is more earliest and most specific finding. Then you see the lateral part of the epiphysis. It is like this, extra concave, and extra growth, that is called as splaying. So we have cupping, that is concavity of epiphysis, the earliest and most specific finding. Then we have fraying, small bony fragments, just like fire, and excessive growth of the lateral part of the epiphysis, that is splaying. This is known as rickets. Does not have white line of Frankel, but when you give calcium, vitamin D, so there is a white line of Frankel that shows that the patient is responding to the treatment. In scurvy, you get a white line of Frankel, but in rickets, white line of Frankel is seen if when the patient is responding to the treatment. Okay. What is loser's zone? Now, there loser's zone is also known as pseudo fracture. Pseudo fracture, or also known as milkman line, small line. So why it is called pseudo fracture? Because once you will give calcium to this patient, it is mainly seen in osteomalacia. It is mainly seen in osteomalacia. Although it can be also seen in osteogenesis imperfecta, fibrous dysplasia, or renal osteodystrophy. Renal osteodystrophy. Mainly it is seen in osteomalacia. But if they ask you single one option, it is seen in osteomalacia. But if they ask you multiple, then it is seen in also seen in osteodystrophy, fibrous dysplasia, and renal osteodystrophy, fibrous dysplasia, and osteogenesis imperfecta. Okay, you can renal osteodystrophy. Now, why it is called pseudo fracture? Because once you will give calcium, it will heal, and it does not heal with callus formation, because fracture heal with callus formation. Fracture heal with callus formation. But please remember, the this loser's zone, pseudo fracture or milkman line does not heal by callus formation. Therefore, it is called pseudo fracture. It is not a true fracture. Seen in mainly osteomalacia, but can also be seen in osteogenesis imperfecta, fibrous dysplasia, renal osteodystrophy. Okay. Identify the sign. Can anybody identify the sign? If you see this white cortex, right area is very less. Mainly it is cortex has decreased and the radiolucency has increased. Okay. This is known as picture frame vertebra. This is called as picture frame vertebra. And this is seen in Paget disease. Paget disease. Picture frame vertebra seen in cases of Paget disease. So I will tell you some important point regarding the Paget disease. Picture frame vertebra, which is seen in Paget disease. Paget disease. Now, what is Paget disease? In Paget disease, there are three phases. First phase is osteoclastic activity. Second is osteoblastic activity. And third is sclerotic phase. In osteoclastic activity, there will be more and more bone resorption. Then there is simultaneously osteoblastic activity, more bones are formed. And then in sclerotic phase, osteoclastic activity decreases and osteoblastic activities increases. So new bones are formed, but these bones are easily breakable. They are brittle. So this is what. So it has a very high turnover. You see, bones are being formed, bones are being resolved. So it has a very high turnover. Now, if you see, there are important things. There is scope for every person, for neuromedicine guy, for ENT guy, for cardiology guy, and for radiology guy. Neuromedicine guy, what will happen? This Paget disease can have 2, 7, 2, 5, 7, 8 nerves involved. So it can involve 4 nerves, that is 2, 5, 7, 8, 25, 78. ENT that can cause otosclerosis. Otosclerosis. So in the MCQ they can give you hearing loss problem. So Paget disease can have hearing loss. Cardiology, since a large amount of bone is formed, there is increased blood supply. There is high output cardiac failure. High output cardiac failure. Now, radiology, what are the radiology signs that is seen in Paget disease? If you come to the uh, skull, you will see because new bones are formed, so it will be cotton wool appearance. In the spine, you have just seen a picture frame vertebra. You can also see ivory side where complete, it is seen during the sclerotic phase, where complete vertebral body is white. So that is called as osteoblastic activity. Let me bring the charger. चार्जर दे दो मेरा वाला उसे डिस्चार्ज उससे चार्ज दे दो एक्चुअली इस 2% बची है बैटरी चार्जिंग में पा इससे चार्ज इतना अच्छा चार्ज है इससे मेरे ख्याल से फास्ट होता जाए 2% ठीक है osteo so this is sclerotic phase so radiology you will see ivory sign that is complete whitening of the vertebral body or you can say picture you can see picture frame vertebra and very important in femur you will during the osteoclastic activity you can see blade of glass appearance or flame appearance blade of glass appearance so I will write down the radiological signs radiological sign in skull you get cotton wool appearance in vertebra you get ivory sign you see in sclerotic phase when the whole of the vertebra will be white please remember this ivory sign is seen in 4-5 places and you can remember them by the example LIMPH L for lymphoma I for infections like TB M for metastasis P for Paget disease and H for hemangioma okay this is what this is lymph so this is ivory sign but mainly it is seen for Paget disease and then you can see picture frame vertebra and in femur you get a blade of grass appearance this is seen in osteoclastic phase so you have to remember these points so you can easily solve the questions of pages now what is this can you tell me yes you see this is white black this is just like zebra this is known as rugger jersey spine. This is known as rugger jersey spine. This is seen mainly in osteopetrosis. And it can also be seen in cases of renal osteodystrophy and brown tumor. This is rugger jersey spine which is seen in osteopetrosis, renal osteodystrophy and Brown's. Identify the sign I have told you. Now, hamburger sign or sandwich sign, can you tell me where it is seen? I have hamburger sign, I don't have the photo right now. Hamburger sign or sandwich, it is eaten to fulfill your stomach, so petrosis. It is seen in osteopetrosis. It is seen in cases of osteopetrosis. So now I have completed your whole Uh, Now, very important point that I forgot is Paget disease treatment. What is the treatment of Paget disease? In Paget disease treatment, since there is osteoclastic and osteoblastic both activities, so you will give biphosphonates plus calcitonin. So if you see my both the videos, 95% of the question will be asked from. Now I will take obs gynae or pharmacology. Okay.